Good morning, everyone, and welcome back to our Upgrade Oncology Pathology series. Very excited today to have two speakers, both from Beth Israel in Boston, who are going to talk to you about clinical pathological radiological correlations with GI and pancreas disease. And I will let them introduce themselves, starting with Matthew and then going to Monica.
Hello, everyone. I'm Matt Rosenbaum. I'm a pathologist at Beth Israel Deaconess, and my specialty is cytopathology with a research focus in gastrointestinal and pancreatobiliary cytology. I also do GI and pancreatobiliary surgical pathology, and one of the bone and soft tissue pathologists as well. So a lot of different small hats I wear. So, yeah, pleasure to meet you all.
Hello, everyone. I'm Monica Vyas. I'm also working at Beth Israel Deaconess Medical Center in Boston, and I'm a GI and liver pathologist. My research interests are focused on neuroendocrine tumors and familial cancer syndromes involving the GI tract. And we're both very excited to be here today. So thank you for having us.
Yes, thank you.
All right, so you guys take it away.
All right, thank you all for joining. So Matt and I are going to talk about clinical pathoradiological correlation in some GI and pancreaticobiliary cases. So gastrointestinal and hepatobiliary diseases form a big component of morbidity and mortality and healthcare expenditure in the United States and worldwide. And though hospitalizations and morbidity are largely accounted for by benign gastrointestinal disorders such as diverticular disease and inflammatory bowel disease, also, our good old peptic ulcers. But the leading cause of mortality related to the GI tract disorders is colorectal cancer, followed by pancreatic cancer. And our work here focuses a lot on diagnosis of both of these. So like any other organ systems, diagnosis of gastrointestinal and pancreaticobiliary disorder involves, crosstalk between clinicians, radiologists, and pathology. So none of us can work in isolation. And a lot of work that we do here in pathology is based on clues which we acquire from our clinical colleagues and from radiologists as well. So various diagnostic modalities are used in diagnosis of GI and pancreatic diseases, and most common being upper and lower endoscopy, and biopsies procured from these endoscopic procedures form a big chunk of our practice. Other advances in these endoscopic techniques have allowed gastroenterologists to use ultrasounds with endoscopes and also perform cholangiopancreatography, also called ERCP, for diagnosis of biliary diseases. And then there are certain non-endoscopic techniques which are also used, X-rays being, age-old, most common, but most of our information these days derive from ultrasound and more advanced techniques such as CT scans and MRIs, and also luminal contrast studies such as, barium swallow and barium enema, and then again, cholangiopancreatography combined with MR, so MRCP, PET, and angiography. So moving on to our first case now. So
yeah, so our first case is a GI case. So it starts with a 69-year-old previously healthy male who's presenting to the emergency room with worsening abdominal distension and chest pain. Like anyone presenting to an emergency room in America, he gets cross-sectional imaging. Although you would also be able to see a degree of this on physical exam or even X-ray for the pleural effusions. So they did find moderate ascites and bilateral pleural effusions on the imaging, as you can see here on the left with the pleural effusions, on the right with a, I'd say it's on the high range of moderate ascites, but it's pretty good there. So the first thing they did, they didn't just rush to doing further studies. They decided to tap the ascites, and they sent cytology. So the cytology is relatively cellular. This is actually a thin prep preparation. That's sort of the bulk of what we do at BIDMC. Although, like we said, the cytologic features are going to be the same, regardless if you use a cytospin, SurePath, thin prep, or any other sort of method. There's a highly cellular specimen, and you can see these clusters of sort of larger cells. I like to use either the cross-sectional area of a neutrophil or a red blood cell. Sometimes you do have lysed red blood cells. Let's see if I can annotate the slides very quickly. Annotate. Here we go. So here's a good example.
Oh, sorry.
No. Here's an example of a red blood cell. Like I said, it's not perfect, especially because a lot of these things do end up getting a little bit blown out of proportion. But I kind of use that as just sort of a baseline sort of for how large things are, especially when looking at images like this. As you see, these are extremely large cells, and and if you look closely, they have high NC ratio, and they have very irregular clumpy chromatin. So these are very, very abnormal looking cells, extremely large, irregular nuclear membrane, large sort of irregular clumpy chromatin. They do have decent sized nuclei, although that's not really specific in this manner. Yeah, and then so this was diagnosed as we also have a cell block too. We use a histogel. Other options, of course, are thrombin clot and colloidin bag. Colloidin bag is extremely labor and resource intensive. I don't recommend that from most places unless you have a lot of experience with that. Thrombin clot is one of those things where if it works pretty well. Usually if you have a very cellular specimen, you can actually get a decent amount out of it. And it's the easiest, I'd say, of the methods to sort of import into the laboratory. Histogel is kind of a middle of the ground one. I like it. It tends to yield very good results in our lab. Anyway, and then you do see sort of a large number of these cells as are large Houston vacuoles as well. And because we had a relatively cellular specimen, we did immunohistochemical stains on it. You don't really see the clumps as well here, but that's fine. So in general, we start with it depends on a little bit pathologist, but we do MOC31 and B72.3. BRIP4 is another option as well. So that delineates basically a carcinoma versus mesothelial cell proliferation. In this case, the MOC31 and B72.3 were both positive. So I'm going to skip to the more sort of informative ones, where we do have relatively high CK7 staining in the abnormal cells. Of course, this will also stain mesothelial cells as well. So this is why you want to start with the other markers as well. Also, there was focal CK20 positivity, and the CDX2 you can't really see here. There's some maybe a little faint staining here and there, but it was not particularly definitive in any way. So we definitely have something here that because of the MOC and B72.1, we can call it a carcinoma. It looks like an adenocarcinoma, especially at those signet ring cells as well. You could also do a mucocarmin stain to sort of further support that, but that's sort of where we're at from our current thing. We don't really have any lineage specific markers that are definitively positive. That CDX2 wouldn't be enough for me to say, oh, this is a colon thing or this is a lower GI thing.
So this patient also had a mental biopsy, and similar to the cell block, we can see here close to the arrow are some cells which contain mucin vacuoles and very peripherally placed compressed nucleus. So these are signet ring cells, and the specimen composed of predominantly fibroadipose tissue with these scattered signet ring cells in this fibrous stroma. And the immunoprofile for this was similar with strong CK7 positivity in most cells and rare CK20 and CDX2 positivity in some of the cells. So together with cytology and biopsy, the findings pointed to a gastrointestinal source for this metastatic tumor involving the peritoneum. The first thing that was done in this case was upper endoscopy to rule out a gastric cancer, and random biopsies from the stomach did not show any cancer. So they proceeded to do further imaging workup of the abdomen. And lo and behold, they did find some thickening in the sigmoid colon here. And you can see the arrows pointing to the sigmoid colon. And radiologists pointed out that the wall of the colon was thickened, And this patient went on to have a procedure outside of our institute, and that resection showed signet ring cell carcinoma involving the sigmoid colon. The patient did come back here and had additional resection, which showed presence of similar signet ring cell carcinoma in multiple foci throughout the serosal aspect of the additional colon that was resected, and also involving fibroadipose tissue. And on the bottom right, you can see a lymph node, which is involved by signet ring cell carcinoma again. So the primary site in this case was lower GI tract. So when we get these cases with metastatic carcinoma involving the peritoneum or pleura, the workup undertaken is for an unknown primary, right? So our basic stains start with CK7, CK20, CDX2, and then we throw in some other organ-specific transcription factors. So in this table here, you can see that many of these transcription factors have very high sensitivity. So TTF1 and CDX2 both have high sensitivity for lung and colorectal origin. And SATB2 is another marker that can be used for diagnosis of lower GI malignancies. And GATA3 positivity would point to breast or urothelial origin. And then PAX8, again, multiple organs can show positivity, including kidney, GYN tract, and also thyroid. So you need to do additional markers in conjunction with these transcription factors to sort of, narrow it down to one particular organ. And then NKX 3.1 is quite sensitive and specific for prostate origin. And various algorithms have been studied to sort of streamline immunohistochemical workup for carcinomas of unknown origin. And based on the CK7, your starting point could be CK7, CK20 immunoprofile, and you can sort of escalate workup in one direction or the other based on what you see. So here's an example from this paper published in Cancers in 2018, which gives a very nice summary of the workflow that can be adapted based on your CK7, CK20 profile. So CK7 positive tumors can be worked up more towards breast and GYN origin. So GATA3 in these cases would point to breast, whereas PAX8 positivity would point to a Mullerian origin, either ovarian or uterine. And CK7 positivity with negative hormone receptors would, in conjunction with TTF1 or napsin, would point to lung origin. Other mesothelioma is one pitfall that always has to be kept in mind, because it will be positive with your cytokeratins, but you have to do additional mesothelial markers to eliminate that possibility. So especially in pleural and peritoneal sites, one always has to consider mesothelioma in their differential diagnosis. And then the CK20 positive arm of the algorithm would focus more on the lower GI tract. So then you start to, try to localize whether the it could be colorectal or small bowel or appendiceal origin. A lot of times we can't tell. So because all of these will be CDX2 and SATB2 positive. Another tumor to consider with CK20 positivity would be bladder urothelial carcinoma. So then you have to do additional markers such as GATA3 to rule out bladder origin. And then some other tumors can also show CDX2 positivity, such as Merkel cell carcinoma and small cell carcinoma of salivary glands. So they have to be excluded by doing additional immunohistochemical workup. I think that was it for this case.
Yeah, I did find out that I feel like the longer I'm in practice, the more I feel like these are relatively sensitive, but get less and less specific as time goes on, all these markers too. But yeah, and especially I think you also mentioned the Merkel cells. I've seen a lot of people, I've seen that often overlooked in consult cases and things like that. So all right, we can go on to part 2. Part two is a younger patient, 27-year-old male, presenting with black stools and followed by syncope. He had a head strike, was taken to the ED. As is tradition, he received cross-sectional imaging, of course. Head and spine were actually negative, so no bleeds, no fractures or anything like that. He had a black emesis and the CT abdomen and pelvis, which showed a 2.5 centimeter mass centered in the gastric fundus, indicated by that arrow there. You can see it's somewhat similar density to the stomach wall as well. It's not really specific, but it is one of the things we do see with this entity. They did endoscopic evaluation. They don't often do cytology on this one, so it's very rare that we actually do get good cytology on it. So when we do, we try to get good photos. So here's photos courtesy of my colleague, Helen Wong, who's one of our colleagues at BIDMC. So basically what we see here, it's a highly cellular, very cohesive neoplasm. This kind of cohesion isn't generally what you see in adenocarcinomas. You say as you get towards malignancy in epithelial cells, or of course in lymphoproliferative as well, you get very discohesive populations. It's not to say you can't have cohesive ones as well, but this is very cohesive, which makes you think it probably is some sort of stroma or mesenchymal tumor. There are no sort of for elucidate, we look a little bit closer. So we both have a diff-quick and a PAP here. They both show somewhat similar features. The PAP does show better nuclear detail, as is standard for the PAP, but the diff-quick is obviously much faster and easier to do in most situations. So what we have here are, these are kind of, they're somewhat monotonous. I wouldn't call them bland. I call them sort of plump, vaguely spindled cells. You could argue here and there might be a little bit of epithelioid appearance to them, but in general, you can sort of see them forming more of a syncytium. They don't really have really obvious clear cell borders. They do have sort of faint nucleoli, which aren't really that horrible looking. The nuclei are very sort of, what's the word I'm thinking of, very homogeneous and elongated, as you see in spindle cell ones. It's, like I said, it's very densely cellular. You don't see obvious anaplasia. You don't see obvious mitotic figures. You see a little bit of nuclear grooving, which is non-specific in this entity, so we're going to sort of ignore that for now. You know, honestly, for this one, you probably would call it a spindle cell or mesenchymal neoplasm, and recommend try to get a cell block to do some immunostaining workup. Most people here, I think most people would be somewhat hesitant to call a distinct entity without any form of histologic or IHC backup. You know, you could argue that for so the sort of the three big spindle cell neoplasms of the stomach, you think of leiomyoma, you think of schwannoma, and you think of GIST. There are, of course, other ones, but those are sort of the big ones. They're going to be very hard to delineate sort of just simply on cytology. That being said, you could argue that for schwannomas tend to be even more elongated. The cells sort of seem very sort of wire-like and sort of pulled out. Leiomyomas traditionally have sort of these very, very dense, thick cytoplasm, which kind of not what you're seeing here. So if you had to get ventral GIST, you could come down side of suggesting GIST. I mean, either way, this patient probably does need to undergo a local resection. They said you actually can do IHC on the cell on the cytology as well. In this case, we did have a needle biopsy, so we did not have to. But I don't want to bury the lead, and I'll let Monica sort of discuss the surgical findings. So they went straight to resection because of the size and sort of worrisome radiologic appearance. I've noticed here that radiology is often actually relatively good at sort of giving you a general categorization for tumors, but I do find that mesenchymal lesions, they do have a real hard time with. I think because it often tends to be isodense with sort of just the soft tissue. They usually just say this is some sort of neoplasm and recommend workup. They don't necessarily say, oh, this is obviously a carcinoma, or we think this is a leiomyoma. They usually are a little bit more vague on that, and I think that's because they just have a harder time really telling what's going on with it.
All right. So this patient underwent a wedge resection for the gastric mass. And here we can see most of the specimen is composed of this mass, which has a very fleshy cross-section. So it's yellow, pretty homogeneous with central cystic degeneration. So that degeneration could be due to the prior procedure, the biopsy which was performed on this case, or it could just be cystic degeneration secondary to tumor growth and the tumor outgrowing its blood supply. So this morphology is pretty characteristic for GIST. Other differentials would include, I'm sure Matt would know more about this soft tissue tumors, but it could be a lipomatous tumor if it was some other area. Neuroendocrine would be another differential to consider in cases with this morphology. So sections of this tumor showed a very homogeneous spindled appearance. So you can see fascicles of spindle cells throughout the lesion, with some blood vessels, thin wall blood vessels in the center. There's no obvious atypia that we saw in these cells, so everything looked pretty monomorphous. And with this morphology, again, as Matt mentioned, for cytology, the differentials would be a gastrointestinal stromal tumor, or a schwannoma, or a leiomyoma. So we did stains in this case, which shows very strong diffuse positivity for c-KIT. And dog1 was positive as well, though it was weak, more weaker than we usually like to see. So the final diagnosis rendered in this case was a gastrointestinal stromal tumor. It was spindle cell type, and we'll get to the types in a minute. And the location in this case was stomach. The size was 2.5 centimeters. Mitotic rate was 4/5 millimeters square, and margins were negative for GIST. So all these things are important to note in the report for risk stratification of gastrointestinal stromal tumors. So before we get to that, gastrointestinal stromal tumors are mesenchymal neoplasms involving the GI tract, and they show differentiation towards the interstitial cells of Cajal. Most common sites include stomach. Small intestine is also relatively common. You can also see them arising in colorectum. Esophagus and appendix are also rarely described sites for this tumor. So clinically, the behavior of GISTs is variable. They have malignant potential. Up to 25% GIST can show metastasis, and about 10% GIST are already metastatic or disseminated at presentation. And GIST can arise sporadically or as a part of other syndromes. So most of them are sporadic, but they've been described in context of the Carney-Stratikis syndrome, which is also known as SDH deficiency, or the GIST and paraganglioma syndrome. And these patients have germline mutations in their SDH genes. They've also been described in neurofibromatosis 1 syndrome, and very rarely patients with germline KIT mutations or germline PDGFRA mutations have also been reported. So the risk stratification of gastrointestinal stromal tumor is a big part of our pathology reporting. This is what our surgeons and oncologists are interested in knowing. What is the risk of progression? And this is based on, this table is taken from the CAP cancer protocol, which is, the standard GIST risk stratification algorithm. So the factors which are considered in risk stratification are mitotic rate, size of the tumor, and then location. So depending on the combination of size, mitotic rate, and location, GIST can be stratified into no malignant potential versus very low risk of progression, or low, moderate, or high risk of progression. So I won't go into the details of this table, but this system is based on a relatively older data set, and many institutions now, especially the big cancer institutes such as Memorial Sloan Kettering, have their own nomograms that they use for risk stratification, which is based on their own data. And the MSKCC nomogram is also available for use freely on the internet. So the more common morphologic subtypes of GIST that have been described are spindle cell GIST, which is the most common, and as we saw in our case, and then a more epithelioid morphology. So epithelioid GIST have more epithelial or oval sort of morphology, and the cells have abundant eosinophilic cytoplasm, more oval nuclei. Nucleoli may or may not be prominent. In this case, they were not that prominent. And they can also have a very myxoid background. So whenever you see a myxoid background in a more mesenchymal or epithelioid looking tumor, always think about a gastrointestinal stromal tumor. And then the morphology of GIST has a very good correlation with underlying mutations. So majority of gastrointestinal stromal tumors are associated with mutations in the KIT gene. And about 70% of GIST have KIT mutations, and they most commonly demonstrate a spindled or a mixed spindle and epithelioid morphology. About 10% of GIST are associated with PDGFR mutations, and those tend to have a more epithelioid morphology. One thing to note with these is they are often negative for KIT by immunohistochemistry. So c-KIT immunostain will be negative. So it's important to do a DOG1 stain in conjunction with c-KIT, especially in cases which have epithelioid morphology. And another small subset of GISTs are associated with either somatic or germline mutations in the SDA gene. So those are typically negative for succinate dehydrogenase B by immunohistochemistry. Oftentimes, these patients are in the pediatric age group or young, very young patients under 40 years of age. So that would be one clue when these patients present with a very epithelioid looking GIST. Definitely do SDHP immunostain to detect any SDH deficiency. And these often have a very plexiform growth pattern. So that would be another clue to look for SDH mutations in these cases. And then very rarely, patients may have GIST which are negative for KIT, PDGFR, or SDH mutations, and those could be explained by mutation in the RAS, RAF, or MEK pathway genes. Those tend to have a very spindled morphology again and will show retained expression of SDHB by immunostain. And then you can have GIST which do not have any of these known mutations, so quadruple wild type GIST, and these are also usually spindled. One caveat to remember while interpreting immunostains and GIST is you need to know if the patient is being treated by imatinib, because treated GIST often can show loss of c-KIT or DOG1 by immunohistochemistry. So if you have a tumor which looks like GIST but does not express your typical markers, look in the chart for any treatment history. They could still have a GIST which has lost expression.
Sort of on that note too, and this is something that that we've sort of become more acutely aware of recently too, especially in upper GI GIST as well. When you're interpreting your IHC, be very careful not to overinterpret especially your c-KIT, because leiomyomas of the upper tract tend to have colonization by interstitial cells of Cajal, and it can be quite remarkable. I remember during my training, there are definitely cases where I had like weak focal staining, and I showed it to Vikram Deshpande, who's actually published on this, one of our colleagues, and he's like, oh yeah, we don't know why, but we, especially in the upper GI tract, you do tend to see quite a few interstitial cells of Cajal, so you really do want that diffuse strong positivity for your KIT and DOG1. And failing that, especially a spindle cell one, you could always get a smooth muscle actin or a desmin, which should be strongly positive in smooth muscle tumors, but negative in GIST.
Yeah, that's a great point. All right, I think we're ready to move on to the pancreas.
Yeah. So pancreatic masses sort of fall in, especially when we talk about radiology, fall into generally solid and cystic categories. Of these, both can be, solid and cystic tumors can be non-neoplastic. Cystic, you'll think of things like pseudocysts. Solid, you can think of things like chronic pancreatitis, autoimmune or otherwise. Both can form cystic or solid masses. On the neoplastic side, that's obviously what we are much more concerned about on pathology. We can have sort of the full gamut. You get things that are completely benign, no need for any follow-up at all, things like serous adenomas, all the way to some of the most aggressive and malignant tumors that we see in pathology. In general, these can be sort of derived by broken down by derivation to sort of things that are derived from the ductal neoplasms and things that are derived from acinar cells. So we can start with the ductal ones because those tend to be at least a smaller number and they tend to be more common. So the main things for ductal neoplasm, think of are PDACs, or ductal adenocarcinomas. Other things you can see are cystic mucinous neoplasms. The terminology for this is always difficult. Some people call them neoplastic mucinous cysts or cystic mucinous neoplasms. The point is that they are cystic and they're mucus producing. The problem is this always gets very close to MCN. I'll talk about that in a second. So the two types of these in general are going to be IPMN, intraductal papillary mucinous neoplasm. These on imaging are going to generally involve the main or branch duct. So they'll connect up to the ductal system. Usually you can also see this grossly when you're dissecting them. The other type is mucinous cystic neoplasms. So MCNs are not the same as just saying, the neoplastic mucinous cysts. That's why I'm saying the terminology is always difficult. But MCNs, mucinous cystic neoplasms, are almost exclusively found in women, usually in the tail of the pancreas. We can start talking about developmentally why that happens at the end if we have time. But they do histologically often look a lot like IPMNs. But the two main differences are that they have ovarian type sperma, which I'll show pictures of later, and that they do not involve the branch or main ducts. There's of course a limit to what you can see on imaging with this, but those are sort of the two main things for delineating the two. They both kind of do behave somewhat similar clinically, even though their populations are a little bit different. So because this is an update, I sort of wanted to discuss the, I don't know if it's going to show up with my background, but this is the new WHO pancreatobiliary cytopathology reporting system. I'm just going to give a very quick update on that. This is from a recently published report by Pittman et al. And basically, people who are familiar with the PAP Society, a lot of it is going to seem very familiar. They did a little bit of condensation and expansion. I'll just briefly go over that. I could give a whole 2-hour lecture just on this system right now, but I'll give a very brief overview. So on the left side, basically, you have the PAP Society guidelines, the PSC, and going to the WHO system. I'm not going to, like I said, I'm not going to spend a huge amount of time on this, but mainly non-diagnostic or insufficient have stayed the same. We have combined negative and neoplastic benign into a benign/negative for malignancies. That includes things like serous cystadenomas. If you just have cyst contents, that makes you think of a pseudocyst. So with things like that, we'll go under now benign/negative for malignancy. Atypical stays the same. It's basically you're just seeing sort of cellular, some small, low degree of cytologic atypia, but you're not really sure what you're dealing with. There's too little to really categorize. Previously, all sort of the mucinous cysts that we talked about, in addition to neuroendocrine tumors and solid pseudopapillary neoplasms, were all under neoplastic other. The big differences are neuroendocrine tumors and solid pseudopapillary neoplasms have gone from neoplastic other to actually being called positive for malignancy. Neoplastic other itself has been broken up into 2 separate diagnostic categories you see on the right, basically pancreatobiliary neoplasm low grade or low risk, and high grade and high risk. Basically the idea is, do you have high grade or low grade atypia on that? Generally, this is supposed to correlate to being an IPMN or some mucinous cyst with low grade or high grade atypia. Important to mention, we used to call low, intermediate, high grade. Now we just call low or high. Moderate has been categorized as low. Suspicious and malignant basically have been kept the same. Like I said, malignant now definitely includes a neuroendocrine tumor and solid pseudopapillary neoplasm. So that's sort of the main changes that we've seen. These do tend to have a pretty good correlation with estimated risk of malignancy. They also have very sort of clear recommendations for management. So you can imagine benign and non-diagnostic have relatively low, decent negative predictive values. There is, of course, a lot of, these are difficult specimens to obtain. So there's a lot of operator dependency here. So that's why you have 5 to 25% to me is a relatively wide range, but the fact is that's still a relatively low risk, so they can repeat or correlate clinically from there. On the other hand, positive and suspicious is very, very high risk for malignancy, as is the group 5, which is pancreatic neoplasm high grade. So basically that's going to be what I think is a mucinous neoplasm or neoplastic population cells, or what we call high grade atypia, which I'll talk a little bit about. As you can imagine, the low grade and the atypical are kind of in the middle there. So if you have something with low-grade atypia and a cyst that's radiologically not worrisome, which I'll talk about in a moment, that means they can just sort of follow them clinically, because radiologically benign-looking cysts with low-grade neoplastic cells in general are very common, and they're generally not terribly aggressive. But so your cutoff is there at high grade. Generally, we recommend them going to either biopsy or just surgical resection. If it's lower than that, basically, they can either repeat biopsy or they can clinically follow based on sort of what we're seeing and what they're seeing. This also has a similar thing for biliary. So this is also used for biliary brushings. Someone has a malignant appearing or abnormal looking stricture, they'll get a brushing. My issue with this, so of course we don't have the pancreatic neoplasm low or high grade designations here. This one is a little bit trickier. As you can see here, the estimated risk of malignancy is relatively high in all the population. So I think this is one of those ones where oftentimes you really just do have to sort of fit what you're saying with clinically. I feel like cytology and biliary brushing is very difficult, but I do find like that it tends to be a little bit more reliable than sort of sampling cystic lesions, because you tend to get high cellularity specimens. The only problem is dealing with reactive changes and sort of the sampling versus make sure you're actually getting the malignant cells versus just abundant reactive cells. But you can see here, at least, you know, and this is sort of dealt with more in the book rather than in sort of the review. You can see here that the estimated risk of malignancy, so when you get to suspicious and malignant, it's very high, which is good because you may not be able to get biopsies in these specimens, but when it is benign and atypical, it's not quite what we want. And I think in a lot of ways, people are starting to recommend doing molecular, doing cell block preparations or doing biopsies, honestly, because I think, this, at least in my experience, this is higher than what I've personally experienced, but, these are sort of amalgamated data. So it's important to know that, these for an biliary side of things, is still imperfect science. I think is still actively evolving. So just to pull out one diagnostic category to very quickly talk about, because I think this is one people often have trouble with, is talking about pancreatobiliary neoplasm, high risk, high grade. So that's sort of that one. So this one is tricky because people often think of being high grade things being large atypical cells. In this case, these are actually often small cells. So what they say is usually smaller than a duodenocite, which you have is GI contamination in there. So it's usually the same size or smaller than a duodenocite. They're not giant malignant looking cells. They do, like malignant looking cells, do have high nuclear cytoplasmic ratios. So they do tend to be very nucleus rich, and the chromatin pattern should be abnormal. So by which I mean you want to see hyperchromasia, or you want to see nuclear clearing. You want to see that abnormal sort of dark chunky chromatin. That is just sort of which is not what you see in reactive populations, which are very common in the biliary system. I have a few very quick pictures as well. So here's some sort of blown up photos here. So, it's very easy to see that these are very high NC ratio cells in general, and you can kind of see the lysed red blood cells on both of them. So on the left picture, you can see them at the top. On the right picture, you can kind of see them in the upper right. So these are not huge cells. These aren't like gigantic cells, but they are very high NC ratio. You can see they are quite hyperchromatic, except for one of the ones in the upper right-hand corner, which is very hypochromatic. The nuclear chromatin is also very irregular. They have a lot, sort of very irregular nuclear membranes. The nuclear chromatin is very dark and chunky, sort of very abnormal looking. So this is what you would call a very good high grade, high risk one. This is associated with, at the very least, oftentimes going to be a mucinous neoplasm. So usually an IPMN, but also possibly an MCN with high grade dysplasia is the histological correlate. Or oftentimes you will see them actually having frank cancer, but we just aren't catching those obvious malignant cells on the cell specimen cytology.
All right, so moving on to our next case. So this is a 72-year-old male who presented with abdominal pain for a week, which was accompanied by nausea, vomiting, and diarrhea. And initially, they were suspecting cholelithiasis, so he was being managed conservatively. And then his labs came back with an elevated CA 19.9. So it was elevated to 177 units. And so he underwent additional imaging studies, which showed a 2 centimeter mass in the uncinate process of pancreas. So I don't know if my arrow is projecting, but you can see a lobulated mass in the uncinate process of the pancreas. And this was subsequently biopsied, which showed This neoplasm, which is rather poorly differentiated, you can see sheets of cells here without any gland formation in this picture. And you can appreciate the pleomorphism in this neoplasm. You can see that the cells are of varying sizes. And the higher power view here shows that many of these cells are actually multinucleated giant cells. And then in the background, again, you can appreciate smaller, highly atypical cells, which have a very high NC ratio. So this is definitely concerning for malignancy. And then very small areas in this biopsy showed some gland formation, but these glands were again very highly atypical. They were right in the stroma, so not detached epithelial cells, but malignant glands within the stroma, which is always concerning for an adenocarcinoma. And all the typical features of a pancreatic ductal adenocarcinoma could be appreciated in these small areas. Again, the background showed histiocytes. You can see pigment within these histiocytes. So hemosiderin-laden histiocytes along with multinucleated giant cells in the background again. So immunohistochemical stains were performed and cytokeratin highlighted the malignant looking glands, as well as numerous single cells and small clusters within the stroma. So definitely concerning for adenocarcinoma here. And the multinucleated giant cells were all positive by CD68, which is a histiocytic marker. So these are all osteoclast-like giant cells, which have been described in a number of malignancies, including one in the pancreas. So the final diagnosis on this biopsy was a ductal adenocarcinoma with an associated component of undifferentiated carcinoma with osteoclast-like giant cells. And this patient underwent subsequent Whipple resection, which confirmed these same findings.
Yeah, so touching briefly on ductal adenocarcinomas. These are traditionally going to be solid tumors, but however, they can undergo relatively remarkable cystic degeneration. I've seen very cystic PDX as well, although it is rare, about 10%, technically around 8% of the cases. These tend to be in older patients, 60 to 80 years old is standard, but I have seen it in young as people in their 20s and 30s, rarely, even without sort of any obvious genetic predispositions that we were able to find, at least at diagnosis. Tend to be more common in men than women, but this is far from specific. And also they tend to be more common in the head rather than the tail. Some of the histologic features that we commonly see are malignant appearing glands, although oftentimes these glands can actually be very, very benign, which kind of makes pancreatic pathology can be very difficult. The 4-to-1 rule basically is within a single gland, be it on cytology and be it in histology, within a single gland or cluster of cells, if you have nuclear size variation of 4-to-1, so if one nucleus is 4 times greater than another nucleus, that is highly concerning. Another really important one is loss of lobular architecture. Of course, associated with these, you do get a lot of chronic pancreatitis, which can look really atypical and create all these really funny looking ductal structures as well. But the trick is these ductal structures will often still respect the lobular configuration of the pancreas. When you start having these funny looking glands in between the lobules, that's when you really should start to worry about a low-grade adenocarcinoma. Another thing that'd be very helpful, and sometimes in certain very low-grade cases, this can be one of the only real clues to the diagnosis, is that when you have these glands very close to nerves or blood vessels, especially large blood vessels, or infiltrating into the peripancreatic soft tissue. There are a lot of imaging findings associated with PDX as well, but probably the most specific and most canonical one that you will see on reports is called the double duct sign. We have dilatation of the distal common bile duct and pancreatic duct. You can sort of see here where the arrow is, the sort of Y shape shows dilatation of both the common bile duct, which is going up on the right side towards the liver, and the pancreatic duct, which is going back to the pancreas. This is relatively specific. It's one of the things that you're taught that is very specific for malignancy of the head of the pancreas, but it's not perfect actually. There's at least in the radiologic community, there actually are some well-known mimics that you have to worry about. I've seen sensitivities and specificities in the 70s and 80s%, which isn't actually bad for a radiologic finding. One paper I saw that was very good showed an odds ratio. Basically, it is if you do see this, that it's 4 times more likely to be a malignant stricture, which may not sound like a huge amount, but considering things like the length of the stricture, which we often worry about, was only like a 1.1, so a 10% greater chance. Or things like low attenuation, which is seen with inflammation, giving you a significantly lower risk of it being an actual malignancy. But like I said, I like the odds ratio because you don't want to necessarily think, oh, this is a super specific finding, because gallstones can actually sometimes cause these, especially if you're not really getting them on, able to get them on the image. You can sort of see, a very tricky gallstone case can cause a double duct sign. It is, at least in my experience, uncommon, but you would never want to sort of put all the weight on the imaging, but it should definitely help inform you. So talking about the cytologic findings, it depends a lot on the histology of the pancreatic ductal adenocarcinoma. I'll talk a little bit later about how there are a wide range of histologies in PDAC. Generally speaking, though, traditionally they are relatively poorly or moderately differentiated carcinoma. So you'll see our standard highly atypical cells here. So here we basically have cells that are sort of very jumbled up. They have very high NC ratio, abnormal dark clumpy chromatin, abnormal sort of irregular nuclear membranes. You could argue that you're probably getting close to the 4:1 cross-sectional area, especially on the lower area. I can annotate very quickly. So let's see, let's get some circles. So you could argue that maybe this one here. Of course, you want to make sure you're not counting lymphocytes, is quite a bit smaller than this one here. It's not the best 4:1 rule I've ever seen, but the point is these are very obvious malignant looking adenocarcinoma cells here. So with when you get a pancreatic mass like this, these ones are comparatively straightforward. However, there are some histologies that are very, very difficult, like the next set of slides, which shows sorry.
This one, or did we jump?
Nope, this is the one. Yeah. Which is a foamy gland variant. So this is one of the classic low-grade types of adenocarcinoma. You can see on the right, sort of they do have, it almost looks gastric in some ways, right? It has sort of a large mucin cap, but the nuclei are very sort of angulated and irregular. In some ways, actually, it's kind of easier to diagnose on the cytology as long as you keep this in the back of your mind. You see this basically a jumbled mess of vaguely atypical looking cells. So I'm using those vaguely atypical because the cells aren't overtly malignant looking like we had in the previous case. They don't have very high NC ratio. They don't really follow the 4:1 rule, not really forming glands or anything like that. But the things that really sort of tip you off here, one, you're in the pancreas and you have a mass, you sort of always keep foamy gland in the back of your head, because if you don't, you're going to miss it. In this case, though, you can see looking at the nucleus, those nuclei are really, really irregularly angulated. Normally the nuclei are going to be at least somewhat round when especially when you're dealing with some things that are, that are benign. These are very, very angulated. The chromatin is a bit abnormal. You could argue it's a little bit chunky as well. There's absolutely no degree of the normal sort of honeycomb architecture that you expect to see. You like to see the cells to be regularly spaced. They are completely irregularly spaced. There's no rhyme or reason to it. People say, oh, look for the drunken honeycomb. This honeycomb is well beyond that fact. There's no real semblance of that left. Also, that sort of presence of that large amount of foamy cytoplasm is one thing that's also highly suggestive of a foamy gland variant. It's always important to keep in mind other malignancies that do have large amounts of cytoplasm. So if you can get a cell block and do just things to rule out, or just get a history, the person has a history of, say, clear cell renal cell carcinoma would be the worst offender. Clear cell renal cell carcinoma can, under certain circumstances, mimic this on cytology. If you look at the cell block, when you have that sort of the glandular mucinous looking appearance, that will look different. But on cytology, theoretically, under the right circumstances, a clear cell can mimic a foamy gland variant as well. That being said, usually you're going to have either a renal mass associated with it or a history of renal cell carcinoma.
All right. So moving on to some histologic examples of PDAC. So on the left, we can see our very typical pancreatic ductal adenocarcinoma. You have very, very bland looking glands sort of infiltrating in the stroma. You can see some of these glands are pretty angulated. So you can, I don't know, Matt, is my arrow seen on, is it projecting or no?
Yeah, it was projecting earlier. Yeah, it's there. I can see it.
Okay. So yeah, I'm pointing out to the angulation here. So you can see very angulated glands in this very desmoplastic stroma. So this stromal response again is a clue and pretty associates pretty well with infiltrative malignancies in the pancreas. So you have this myxoid stroma with spindle cells, very sparse inflammatory infiltrate, and then angulated, very bland looking glands. These are, they don't follow your typical like lobulated architecture that you would see in chronic pancreatitis. So these would be like, very irregularly scattered about in the stroma, which would again be a clue that this is probably, these are malignant infiltrating glands. And then if you can appreciate smaller clusters and maybe single cells in the stroma, that would definitely be very helpful in clinching the diagnosis. And again, as Matt had pointed out, if you can see perineural invasion or presence of a very bland looking gland right next to a thick walled vessel, which would be an artery, that would again be a clue that this is actually in an invasive carcinoma, because unlike the liver, where you have a triad of artery, vein, and bile duct going together, in the pancreas, you don't have ducts along with the blood vessel. So you should have an artery associated with a vein. But instead of vein, if you have a very bland looking duct next to an artery, so that probably represents colonization of the venous wall by ductal adenocarcinoma. So always be aware of those naked arterioles associated with ducts or ductal adenocarcinoma, actually. And then here's a high power view. This would definitely not be, challenging in any ways, because you can see a very complex atypical gland. You have some single cells trickling out, and then you have a lot of pleomorphism here. So you have some smaller looking nuclei, and then other nuclei, which would maybe nucleus, which would be maybe like 3 to 4 times the size of the nuclei in the background. So this this particular focus also shows necrosis within the lumen of the glands, which is again an indicator of malignancy. So this is a very typical example of pancreatic ductal adenocarcinoma. But again, you have a lot of morphologic variants, and the most common one that we see in practice is the foamy gland variant. You just saw cytology of that. And here's an example of histology from a similar case. So you can see these glands have a very clear epithelial lining, and oftentimes the nuclei are very small. Sometimes they're even squished close to the base. And one of my attendings used to say the nuclei are pickled because they always have this dense, shriveled look to them. And oftentimes you can also appreciate eosinophilic condensation at the luminal aspect or luminal border of the glands. So that is due to a villous brush border. So those are all typical features of foamy gland variant of pancreatic ductal adenocarcinoma. Here's an example of a very poorly differentiated or undifferentiated carcinoma involving the pancreas. So you have a sheet like a distribution of very atypical malignant looking epithelioid cells. You have frequent atypical mitoses here. There is a fair degree of pleomorphism which this tumor is exhibiting. So you have some nuclei which are really big and irregular with prominent nucleoli, and then other background nucleoli are much smaller. You can also appreciate that some of these cells have eccentric eosinophilic cytoplasm, so sort of a rhabdoid looking morphology. So it would be prudent to do INI1 and BRG1 stains on cases like this, because these could be associated with mutations in one of the SMARC genes. So that's an example of a poorly differentiated or undifferentiated neoplasm. Another differential to consider in these cases would be to consider EBV-associated tumors or medullary carcinomas of the pancreas. So when you have undifferentiated tumors like this, it might be a good idea to do mismatch repair IHC or even EBER. EBER-associated neoplasms have been recently described in the ampulla as well. So, and ampullary carcinomas can often present with pancreatic head masses. So another differential to keep in mind there. And here's a histologic example of the same case which we saw on biopsy before. So this is a ductal adenocarcinoma with a component of undifferentiated carcinoma with osteoclast-like giant cells. So you have a component of tumor which is very poorly differentiated, the sheets of small malignant appearing cells. Some of them also look spindled here between the glands and the undifferentiated component. And then you have multiple osteoclast-like giant cells. So these tumors typically have a better prognosis than pancreatic ductal adenocarcinoma. So this is something to keep in mind, and a variant that should be mentioned at the time of diagnosis. And depending on the proportion of your typical ductal carcinoma in the tumor, the prognosis may vary. So a tumor which is entirely composed of undifferentiated carcinoma with osteoclast-like giant cells would behave much better. A tumor with mixed morphologies may behave well, but not as well as a pure undifferentiated carcinoma with osteoclast-like giant cells. And then your pure PDAC would have worse prognosis. So mixed tumors would have an intermediate prognosis between the two morphologies. So that is something to keep in mind in these cases. And then on the bottom right, we have an example of a colloid type carcinoma of the pancreas. So this morphology is the glands, the tumor is composed of lakes and pools of mucin within the pancreatic stroma. And then some of these pools may be either completely or incompletely lined by lining of neoplastic cells. So we can see on the top left corner of this picture, there's a big pool of mucin, which is lined by neoplastic epithelium. And similarly, on the right side as well. So this morphology is important to recognize, especially in conjunction with intestinal type IPMNs, because they often show a colloid carcinoma component. Again, the prognosis of these tumors is very good, of course, depending on the stage and extent of invasive carcinoma. So this is another variant that we're going to talk about, but here's an example of a pancreatic transection margin, which was received for frozen section. And you can see there are multiple dilated big ductular channels here, and some more smaller glands. So on low power, this looks like, you know, could this be chronic pancreatitis secondary to obstruction? You have this duct dilatation. And then on higher power, you see a lot of these glands and then islets and background stroma. It's very fibrotic. So again, suggestive of maybe chronic pancreatitis. And these ducts look very bland. Some of them are very large, as we saw on a low power image. So this would be really tricky to diagnose on frozen section. So the question would be, is this margin positive or negative? But one needs to be aware of this variant of PDAC again, which is called a large duct variant of PDAC, which is composed of very large glands with very bland looking epithelial lining, but it is carcinoma. So one needs to be aware of this variant, and especially while dealing with frozen sections, always keep that in mind. And here's a immunostain for SMAD4 or DPC, which shows loss of SMAD4 expression in these glands, which is diagnostic of pancreatic ductal adenocarcinoma in this case. So this is another variant of PDAC, which should be kept in mind. And then there are other histologic variants of PDAC which have been described. So adenosquamous carcinoma is one variant which we see pretty commonly. So they're composed of a glandular component and a poorly differentiated component which has a squamoid morphology, and that would label with P40 and P63, which are stains for squamous differentiation. You can also see hepatoid variant of adenocarcinoma. So this variant will have a hepatocellular morphology and would label with hepatocellular markers as well. And these patients can also have elevated AFP, which can be tested on serology. And then we talked about the medullary variant briefly. So that would again be a very poorly differentiated syncytial growth pattern with a robust inflammatory infiltrate, and good to do immunostains for mismatch repair proteins in these cases, as that could have treatment implications. And we will get to that in a minute. And then there are other variants such as invasive micropapillary variant, signet ring cell carcinoma of the pancreas, and then undifferentiated category, which includes anaplastic carcinoma, sarcomatoid carcinoma, and carcinosarcoma of the pancreas. And then briefly about the molecular associations of PDAC. So most frequently altered genes in PDAC are KRAS, P53, CDKN2A or P16, and SMAD4. So this is the typical landscape of pancreatic ductal adenocarcinoma mutations. And up to 25% of PDACs can have actionable mutations. So very important to do sequencing in these cases. For example, a subset of pancreatic adenocarcinomas can have mutations in the BRCA genes, and that would make them amenable to PARP inhibitors. And a subset of PDAC, though very rare, less than 1% of PDACs can have loss of mismatch repair proteins by IHC. And these patients typically have Lynch syndrome, but then that would make them candidates for immunotherapy. So that would be another indication and consideration for next generation sequencing. And then transcriptomic analysis of PDACs have shown various classes of pancreatic ductal adenocarcinoma based on their transcriptomic features, and those might be predictive of their outcome. So the most commonly talked about categories are classical and basal-like, and the basal-like morphology includes squamoid and poorly differentiated carcinomas, which tend to have a more worse prognosis. So yeah, I think that was about PDAC. Matt, do you have any comments?
No, I think that's enough. I still have nightmares about that large duct case, but yes.
Yeah. All right. So moving on.
Yeah, I have a case for this is gonna be our last of our very long cases. I know we're at an hour, and we'll try to get through the rest of them very quickly. This one is a little bit long because I start talking about this whole class of entities, which is very, very common and very important. So after that, we'll pick up the pace a bit more. This is an 80-year-old male with a large number of comorbid conditions, have a 4-centimeter multicystic pancreatic mass in the head of his pancreas during workup for incidentally found during workup for prostate cancer. Basically, on MRI, they did show internal septations, and a central hypointense focus is concerning for malignancy. You can kind of see a little bit of enhancement around the edge, right where the arrow is, and you can sort of see that little grayish area in the middle too. Is both sort of concerning findings. There's no obvious connection to the main pancreatic duct, but it's a very poor surgical candidate. So they sort of wanted to do biopsies and cytology. Unfortunately, cytology wasn't hugely helpful in this case, but the biopsies are actually ended up being quite good. So basically their thing is they wanted to rule out cancer. This person has a lot of other issues going on. So if they can rule out cancer, they can sort of just follow him until, as long as need be. So we can take a quick look at the biopsy, and I'll talk a little bit more about the cytology in a moment. So the biopsy showed strips of gastric type epithelium, no obvious high-grade dysplasia, no obvious issues here. So it basically looks very very similar to stomach, but you sort of see that some areas where there is definitely papillary formation. And you don't sort of see any other features that makes you think you're actually in the stomach. They also, the tract, if you look at the biopsy tract and things like that, for this case, you can tell they weren't going to the stomach. So in this case, we're very sure that what we're dealing with here is actually, biopsies from the cyst in general. So basically this is low-grade gastric epithelium. This was repeated multiple times. They weren't fine just doing it once because this is a very concerning radiologically finding, but basically this suggests a low-grade IPMN, at least in what they have here. Of course, sampling bias is always a possibility. This brings us to our discussion of cystic lesions of the pancreas. Pancreatic cysts are extremely common. The more you look, the more you're going to find. Basically, in this era of overuse or just high prevalence use of cross-sectional imaging, they estimate that anywhere from 2 to 15 or so, or 13.5% of patients with no symptoms have some form of cyst in their pancreas. It goes up as you get older as well. Broad differential diagnosis for things that are completely non-neoplastic to things that are highly malignant. And sort of because of that, the management just may be fine, go home, don't worry about it, or go through a Whipple procedure or something like that, or go straight to chemoradiation. So we rely on cytology and and imaging to sort of guide that initially. There are a lot of imaging guidelines, so I'll talk very briefly about the imaging ones. Currently, at least there are at least 5 set of guidelines for imaging pancreatic cysts. 3 of them are from American associations, 1 from European, 1 sort of more international, the Fukuoka guidelines. I have sort of the worrisome features on the next one. I'm not going to go through all of them, but you can see they're all vaguely different. So the American College of Gastroenterology focuses a lot actually on sort of more clinical findings, as you expect, since they're gastroenterologists as opposed to radiologists or surgeons. So they're the ones to talk about things like CA19-9 or sort of more acute pancreatitis or diabetes and things like that. A lot of people do talk about the this is all for ones that are indications for surgery. I'll show you sort of the ones I picked out as being the most sort of the commonalities between them in the next slide. Is generally if you have relatively dramatic pancreatic duct dilation greater than 1 centimeter, especially in the absence of like a gallstone or anything like that, that would cause dilatation due to an obstruction, a mechanical obstruction. If you have a mural nodule, basically a solid area of it, that is very highly concerning. If on cytology, if high-grade cytology, so basically that sort of is that pancreatobiliary cytology high grade, like I showed earlier, but those small high nuclear cytoplasmic ratio cells, suspicious and positive, also count as high grade or worrisome cytology. The criteria for large size kind of varies. So basically just in general, more cyst is more worrisome. And sort of clinical findings such as jaundice particularly is very concerning. So those are sort of the ones that they call, they're just general commonalities between most of them. So if you just see any of those on the imaging, they're the things you can worry about. So like I said, there are a wide differential diagnosis. The most common ones are going to be pseudocysts, so someone who has some form of pancreatic injury, has basically cystic degeneration of the pancreas. Mucinous neoplasms are also very common, with everything else sort of being, and serous cystadenomas being somewhat common. 200% is a little high for me, but that this is the published data. But in general, sort of cystic degeneration of solid tumors are less common. But so in general, pseudocyst, mucinous neoplasms, and serous cystadenomas are the most common, with other things being less common, but still definitely seen. So I'll just briefly touch on pseudocyst. Pseudocyst is generally give a pancreatic injury. So most commonly pancreatitis due to alcoholism, due to gallstones, or due to some form of trauma. Abdominal trauma can cause pancreatitis. Generally, once the acute pancreatitis resolves, you have this cystic space. Usually more common in men than women, though this does depend on sort of your population. You can do cyst fluid studies. I'm not going to talk too much about these, but in general, CEA is the one I care most about. High CEA, which is defined as greater than 192 nanograms per milliliter, is indicative of a mucinous cyst or a neoplastic cyst, basically. That's an abnormal type of mucin to be seeing, greater than 192. That makes you think of either an IPMN, an MCN, or a PDAC. That's generally what you're going to think about. Amylase is less useful. Amylase tells you that you are in the pancreas in general. It's something that's somehow connected to the pancreatic duct. You can see high amylase in cancer. You can see high amylase in IPMNs. Usually it's going to be really, really high in pseudocysts, but it's not as useful. So for me, the CEA is, if you're going to do biochemical studies, CEA is the one to get. A little bit annoying to actually perform, but if you can get it, wonderful. Histology, it's not really a true cyst. There's no true cyst lining, although you can have sort of a histiocytic lining that looks like a true cyst lining. Cytology is going to be kind of non-diagnostic, but I'll show you a good example in the next slide right now. So generally speaking, in the cytology, you're not going to see epithelial cells because, like I said, this is not a true cyst. You will see a lot of hematoidin and hemosiderin-laden macrophages. You'll see sort of digested blood. You'll see all these things that basically makes you think of something highly inflammatory. If you see this and it fits very well with the clinical finding, you can basically say this is benign / non-neoplastic. Basically, because everything fits really well together with acknowledgement that, you know, could there be something else there that you're just not seeing? That's always a possibility of cytology. If you're lucky enough, or sometimes, you know, these do get resected just due to causing symptoms or there being other concerns. And here's just some good examples of what you see. That's the sort of histiocytic lining on the left, and sort of more just that sort of debris on the right as well. All right, in the short time, I'll try to move it along. Mucinous neoplasms, as I said before, IPMN, MCN are the most common. They can have basically low grade or high grade dysplasia. Clinically speaking, you always want to look at the scope report, because sometimes they will have sort of thick mucin when they actually introduce the needle, and that you can use that data in your diagnosis too. You know, you might want to mention that you're basing it on the clinical findings as well, but that thick mucin, if you're lab tech or you see it eventually, that's very suggestive of a neoplastic cyst. Usually other things don't produce thick mucin. If you're lucky, you will get mucinous epithelium. These can be very polycellular, so it can be very tricky. These are neoplastic, these are pre-malignant. So given enough time, any of these can get larger and larger and turn into cancer. Generally speaking, if it's a low-grade small one, it's going to take decades and decades, and the person's probably going to die from something else. So generally speaking, we just follow those clinically with imaging or repeat cytology, unless they get bigger and bigger, and then they worry more about them. So briefly talking about IPMNs, usually it's a slight male predominance. Usually older patients, more commonly in the head of the pancreas. This is all in contrast to mucinous cystic neoplasms. They can involve the main duct, which is generally clinically more concerning. The side branch duct, or both. If it's a mixed, it is kind of treated more on. They're a little bit more worried about being a main duct one, so they tend to be a little bit more aggressive about that. The types of epithelium is either gastric type, so it looks like foveolar epithelium. Intestinal type looks like intestinal epithelium, or pancreatobiliary type. There's a rare oncocytic type. It looks oncocytic. Highly atypical looking, is pretty rare. I've only seen a couple cases of that as well, but it tends to be moderately aggressive. Traditionally speaking, we used to call gastric type low grade, pancreatobiliary type high grade, intestinal moderate grade. We don't do that anymore. All three of these types can have low, moderate, and high grade dysplasia. Once again, as we like to do in cytology, we now group the bottom two, so low and moderate, into low grade dysplasia and high grade dysplasia. That's increased our kappa ratios significantly. So nowadays, pancreatobiliary is generally going to be high grade, and gastric is generally going to be low grade, but you can have a high grade gastric, and you theoretically can have a low grade pancreatobiliary. I don't know if I've seen more than a couple cases of that. So these cysts are off. The problem is this is a cyst. Cyst, unless you are lucky enough to actually get, you know, cells on it, so oftentimes you're just going to get this thick mucin. So the term that Dr. Pittman sort of coined, I don't know if she coined it, but she certainly likes it, is thick colloid-like mucin. So it looks kind of like a thyroid biopsy. You will sometimes see cracking, but the point is you really want to see this thick mucin. So this is not the kind of mucin you see just from gastrointestinal contamination, which is always going to be your main differential diagnosis, is GI contamination. Like I said, if you see it grossly, either you see it or the endoscopist sees it. That's also something you should mention in your report as well. So the gastric type ones are kind of going to be the trickiest one, because oftentimes you're going to be either going through or going around the stomach. In this case, if you see sort of papillary fragments, or sort of these three-dimensional fragments of mucinous cells, that makes you think that you're really getting true cyst sampling. I could talk for hours on mucinous cysts of the pancreas. They're very fun to talk about. But this is a good example of at least a somewhat papillary, somewhat three-dimensional kind of look. Around the edge, you do have some degree of sort of picket fencing, but on sort of the center, it's all kind of jumbled up. So this is a good example of gastric type epithelium. Like I said, gastric type can have degrees of atypia. So if you look at the next slide, you can see on the left, you have low grade. On the medium, you have moderate grade, which once again, we call that lower grade. The NC ratio is getting higher, they're getting more hyperchromatic, but you can still see a decent amount of polarization. And then on the right, you have high grade dysplasia. We have much higher NC ratio. You have the cells themselves, like I said, they aren't gigantic. This is high grade. This isn't like overtly malignant. You do see hyperchromasia and sort of more degrees of cellular atypia. We can come back to this later if we have time, but this is sort of the general thing of it. I have some more pictures of high-grade atypia on the next one. Like I said, generally speaking, you do want these are relatively small cells. So these aren't like the giant malignant-looking cells you see in a ductal adenocarcinoma. You see they're generally about the same size or smaller than a duodenocite. So once again, that's going to be 12 microns or so. But if you have well-preserved red blood cells, that's about a red blood cell and a half, depending on your patient's MCV and things like that. I do caution about using that, but like I said, in a pinch, if you have to, you can use a red blood cell or the cross-sectional area of a neutrophil to be about 7 microns, give or take. So about 1.5 of those, as you can see, that's about right for that. High NC ratio, hyperchromasia. These are definitely atypical cells, but they're not overtly horribly malignant looking, but these are definitely worrisome. So we would call these pancreatobiliary neoplasm with high-grade atypia. And basically, this means that patient really does need some form of surgery or ablation, because this is going to be, at the very least, a high-grade IPMN. Chances are it's going to be associated with an invasive cancer as well.
All right, so moving on to resections of intraductal papillary mucinous neoplasms. So as Matt mentioned briefly, in radiology, radiologists are pretty good about, classifying these into main duct type and branch duct type. So main duct type IPMNs are connected to the main pancreatic duct, whereas the branch duct IPMNs are connected to one of the smaller branches of the main pancreatic duct. And it is important to note the difference because the main duct IPMNs have a much higher chance of invasive malignancy. So about 60% of them can have associated invasive carcinomas, whereas only 15% of branch duct IPMNs ever show invasive carcinoma. So there's a clear difference in the biology of the two. So here's an example of a resection specimen, which is showing a large cyst here, which has been opened up. And you can see the probe here is passing through the main pancreatic duct. So this cyst definitely communicates with the main duct. And then you can see areas of irregularity, some tan red granular looking mucosa in the center, right adjacent to that yellow looking focus. And you definitely want to sample any papillary looking or solid areas, but the general recommendation is to submit the entire cyst if you cannot see a clear invasive carcinoma associated with it. So oftentimes we get pancreatic resections, which are 5 or 6 trays and, slides running in hundreds because we couldn't see a clearly invasive component, and we end up submitting the entire cyst lining for evaluation. So here's a histology from that case showing a very nice involvement of the main pancreatic duct here, which is pointed by the red arrow. So that's the main pancreatic duct. And then right next to it, you can see this large cyst with multiple papillary projections in the lumen. You can also appreciate that thick mucin, which looks almost grayish over here. So thick mucin in the cyst cavity with these papillary proliferations, which are projecting from the wall of the cyst. So definitely low power appearance of an IPMN. And again, on histology, we can see the same histologic subtypes that Matt talked about on cytology. So gastric type IPMNs are the most common, up to 70% of IPMNs have this gastric type lining, usually low grade. So you can see this, the lining here has multiple papillary projections and very bland columnar low-grade lining with this foveolar mucin cap on top, and no definite high-grade dysplasia in this case. So this is an example of a gastric type IPMN. Gastric type IPMNs can also be associated with invasive carcinomas, and usually the morphology of invasive carcinoma in those cases would be like a tubular type carcinoma, so kind of like your ductal adenocarcinoma. And on the bottom right, you can see an example of a pancreaticobiliary type IPMN. So you have papillary projections, which are lined by this more high-grade looking epithelium. You have micropapillary tufts arising from this epithelium, and you do not see a clear mucin cap in these. And because of this tufting and atypia, in certain profiles, you can also appreciate that the nuclei are not polarized, so they're kind of like scattered anywhere in the cell. So in some places they are present more centrally, or in some areas you can appreciate that touching the luminal border on the top, whereas in some areas they are basal, so they have lost polarity. And this is an example of a pancreaticobiliary type IPMN with high-grade dysplasia in this case. Again, pancreaticobiliary type IPMNs can also have invasive carcinomas, actually a very high chance of invasive carcinoma associated with them. And again, morphology would be more tubular type or conventional ductal adenocarcinoma type in these cases. And here's an example of an intestinal type IPMN. So again, papillary projections, which are lined by pseudostratified type epithelium. And you can see there are scattered goblet cells. They have gray-blue mucin in contrast to gastric mucin, which was more pinker on histology. So they have this gray-blue type of mucin. And in this particular example, it's showing only low-grade dysplasia. So again, features of high-grade dysplasia would be loss of polarity, micro papillary projections or tufting, and increased NC ratio, more nuclear atypia, and rounded nuclei. And so intestinal type IPMNs can be associated with invasive carcinomas. And as mentioned before, they're usually associated with this colloid type carcinomas, which have pools and pools of mucin involving the pancreatic stroma. And these mucin pools can be lined by neoplastic epithelium, or you can even see floating strips of neoplastic epithelium within the mucin pool. So when you have that is pretty characteristic of a colloid type carcinomas. Sometimes IPMNs can rupture and you can have mucin extravasation in the stroma. Usually that mucin extravasation would be accompanied by some sort of reaction, in contrast to, bland stroma of colloid carcinomas. And mucin extravasation usually would not be lined by neoplastic epithelium, nor would have floating neoplastic epithelium within the mucin pool. So those are two features to definitely watch out for when dealing with, mucin pools in context of IPMNs. And then another neoplasm, which is often discussed along with IPMNs, but now we know that it's not in the IPMN family, is intraductal oncocytic papillary neoplasm. So they have similar cystic appearance on imaging and gross examination. They have papillary formations, but the epithelium has some certain peculiar characteristics. So you can see that the epithelium has abundant eosinophilic granular cytoplasm. The nuclei are large, vesicular with prominent nucleoli, and they can have, so this is the classic appearance of an oncocytic neoplasm with abundant granular eosinophilic cytoplasm. And then you can find scattered goblet cells within these epithelial linings. So it's not continuously lined by mucinous epithelium, but has only scattered goblet cells. So that is a characteristic of intraductal oncocytic papillary neoplasm. And now we know that these are genetically different from IPMNs. And these by definition are high grade. So there is no low grade category in this. And they also can have invasive carcinomas associated with them. So here's a little brief overview of immunohistochemical features and molecular associations of intraductal neoplasms of the pancreas. So IPMN has three categories: gastric, intestinal, and pancreaticobiliary. And by IHC, the mucin stains will show positivity for mucins associated with that particular type of epithelium. So gastric IPMNs will have MUC5AC positivity, whereas intestinal type IPMNs will be positive for MUC2 and also CDX2 and CK20. And pancreaticobiliary lining would be positive with MUC1. And IOPNs, or intraductal oncocytic papillary neoplasms, would be positive for MUC6 and MUC1 both, more so MUC6, but they also show positivity for hepatocellular markers. So that is one thing to keep in mind while making this diagnosis. They can show expression of HEPAR1, or in certain cases, also albumin-ish by in situ hybridization. And then ITPNs is something we didn't discuss, but is often discussed along the same lines as these are the intraductal tubulopapillary neoplasms of the pancreas. These, by definition, again, are high grade and have a high chance of invasive malignancy. And usually they show pushing type of invasion, so very, very difficult to diagnose on small specimens. They also show MUC6 and MUC1 positivity. So molecular features of IPMNs are usually overlapping. So they typically show either KRAS or GNAS or RNF3 mutations. Less commonly, they can have TP53 mutations, P16, SMAD4, DPC4, PIK3CA, AKT1, or show loss of P10 as well. And these are usually associated with the high grade features in IPMN. IOPNs, as I mentioned, are a different class of neoplasm. So they are characterized by fusions involving the PRKACA gene or PRKACB gene. So the DNA JB1 PRKACA fusion, which was thought to be diagnostic of fibrolamellar type of hepatocellular carcinomas, have also been detected in IOPNs and are quite characteristic. And ITPNs commonly have a different molecular profile too. So they can often harbor P53 mutations, P16 or CDKN2A, and then ATRX, BAP1 mutations, and sometimes also show FGFR3 fusions. So this was like a very brief and quick overview of molecular features of intraductal papillary neoplasms. So amongst the cysts which are not connected to the main pancreatic duct, one class to remember is the mucinous cystic neoplasms, and Matt quickly went over that. So I will just give a brief review of histology. So in this case, so here we see a simple cyst, which is not septated, not multilocular, but has a very, we don't see papillary projections projecting from the wall either. So a very simple looking cyst of the pancreas. On sections, it shows lining by very bland mucinous type epithelium. And diagnostic feature of this entity is detection of ovarian type stroma in the cyst wall. So here you can see the spindle cell proliferation, very bland looking spindle cells. If we did not know that this is the pancreas, and if you were only shown these spindle cells, you would think that, okay, you could be in the ovary. So this is ovarian type stroma. And you can also see it on small specimens. So I think Matt gave this picture of a MCN with ovarian type stroma here, and the stroma is highlighted by inhibin here. Is that correct, Matt? Any more cytologic clues on this one?
No, it's very, very rare to get the stroma on cytology itself. So your best hope, even this, I've had very few cases of core needle biopsy where I get good stroma. This is probably one of my few cases that I have for that. So it's gonna be a tricky one to delineate on cytology and small biopsy.
Yeah, absolutely. And then on resection, the ovarian type stroma can be highlighted by stains for estrogen receptor, progesterone receptor, and inhibin also shows positivity in these cells. In our experience, progesterone receptor works much better. It shows very nice, strong labeling for ovarian stroma, whereas estrogen receptor can often be weak. So we prefer doing PR on these cases to look for the stroma. So very quickly, mucinous cystic neoplasms show a very striking female predilection. So most cases described are women, and they're usually seen on the tail of pancreas. Rarely they can involve other organs too. So they've been described in the liver, bile ducts, and gallbladders. The chances of having an invasive component in these is less than that for IPMN. So 1/3 of IPMNs can have invasive malignancy, whereas in IPMNs, it's around 15%. And usually the invasive component is seen in the form of mural nodules, which is solid nodules within the cystic lesion, or you can sometimes see incidental invasion within the septae as well. So it's important to submit the entire cyst wall in these cases to look for invasive malignancy. Morphology of invasive carcinoma can be tubular, undifferentiated, or papillary. It's now known that the colloid type carcinomas, which is seen in intestinal type IPMNs, are not seen with MCNs. And then the outcome is worse if invasive component is more than 2 centimeters in size as expected. So 5-year survival rate is almost close to 0 in such cases. So definitely important to document the size of invasive component as well. So moving on.
Yeah, moving on. All right, we've theoretically have half hour left. I'm happy to stay a little bit longer for questions and things like that. So we'll try to push through these ones pretty quickly. So this is a case 5, 63-year-old man presenting with abdominal pain and weight loss. You can see there's a sort of poorly delineated 3.5 centimeter mass in the uncinate, but also these large, terrible looking liver lesions as well. We're actually able to get some cytology on this case, which shows sheets of epithelial cells. They are kind of, they're definitely atypical. They're a little bit homogeneous. You can see sort of thick eosinophilic, almost eosinophilic cytoplasm. They have large, sort of relatively monotonous looking nucleoli as well, relatively high NC ratio. This isn't 100% specific on cytology, but the fact is that you have this relatively dense cytoplasm, quite a bit of the cytoplasm, and these sort of distinctive monotonous but atypical looking nucleoli is highly suggestive of an acinar lesion. The cell block, unfortunately, is actually less atypical looking. So sometimes you can get nice sheets of the cells, and that really makes you like, okay, this is obviously an acinar one. But sometimes when it's actually forming acinar proliferations, it's hard to really tell if this is truly atypical or not. Luckily, the cytology was more helpful in this case than the sort of the small needle biopsy. So this patient did actually have a core needle biopsy, which is also very helpful too.
Yeah, so the biopsy shows this very poorly differentiated neoplasm with nested architecture, as you can see in the low power image on the left side. And on high power, again, the features that we see are, very atypical cells. They have eosinophilic granular cytoplasm. The nuclei are large. So in some cells, you can appreciate that the nucleoli are quite prominent, and you can see frequent mitotic figures in these neoplasms. So that is actually very useful to distinguish from well-differentiated neuroendocrine tumors, which can sometimes look similar. So immunohistochemically, in this case, trypsin was sent out and it was positive. We can see this nice granular positivity for trypsin granules within the cytoplasm. And again, as Matt mentioned, they can have various, morphologies. So here's an example of the acinar type morphology in these. And when they're present in a tissue specimen like this with back-to-back arrangement and obvious atypia seen, it's less of a diagnostic challenge. And in fact, a good clue that this may be a acinar cell carcinoma, but oftentimes when atypia is not significant, it could be a challenge to diagnose these. And then you can also have trabecular architecture, as you can see in the image on the lower right. And oftentimes you can see these secretions, which are these eosinophilic concretions present within the lumina of the glands. So these are secretions of the acinar cells, and when found, they can also be pretty useful in making the diagnosis. So acinar neoplasms of pancreas encompass multiple entities. So acinar cell carcinoma being the most common. And in the pediatric age group, you can see pancreatoblastomas, which morphologically look just like acinar cell carcinomas, but have scattered squamoid morules. So that would be a diagnostic feature. And obviously age would be another indicator. In these cases, you can see pancreatoblastomas in adults too, but they are very rare. And then you can have mixed neoplasms, which can have an acinar component. So you can have mixed acinar ductal neuroendocrine neoplasms and mixed acinar neuroendocrine neoplasms. Oftentimes in these cases, it's either the neuroendocrine carcinoma component or acinar cell carcinoma component, which would be metastatic and would dictate the prognosis. So, and then you have some benign entities like acinar cystic transformation, which are just cysts lined by very bland looking acinar epithelium. And we now know that this is a reactive phenomenon from duct obstruction and not really a neoplasm. So I don't want to go into a lot of details, but these neoplasms are very rare, and the presentation is usually non-specific, just like any other pancreatic malignancy. And they often present with liver metastasis. And you can have lipase hypersecretion syndrome in these cases. So patients will have fat necrosis, eosinophilia, and joint pain. And as mentioned, they can often have metastasis at diagnosis, and then molecular profile is rather heterogeneous. So you can see BRAF fusions in a good subset of cases, and then these can demonstrate mutations in KRAS, beta-catenin genes, SMAT4, P53 gene as, name it, and every gene is there, BRCA and mismatch repair genes as well. So I think we have gone over the histology in detail pretty much, but just to mention other immunostains that can be used for diagnosis, we saw an example of trypsin. Another enzyme in pancreatic acinar cells is chymotrypsin, which is also pretty specific, and immunostain against that can be used in diagnosis. BCL10 is a very sensitive and specific stain, which is relatively new, and the antibodies directed against the C-terminal of the lipase enzyme. So again, pretty specific for diagnosis of these entity. One pitfall to remember is that acinar cell carcinomas can have focal expression of synaptophysin. So if acinar cell is on your differentials, I would say wait for your trypsin BCL10 stains to come back before you call something neuroendocrine based on focal synaptophysin positivity, because that is a pitfall that is often observed in these cases. So
All
to the
right,
next case.
moving on to case 6 is a 54-year-old woman with an incidentally discovered 3-centimeter head of pancreas mass. You can sort it right there in the middle with the arrow. It's they got cytology on this, so we do have the FNA results.
Yeah.
So this is a relatively characteristic case. You've a sort of homogeneous population of plasmacytoid looking cells, so a relatively large amount of abundant cytoplasm, eccentrically located, round to oval looking nucleus. With, you could argue that there's some, you can't really see it here, we'll take a little bit closer in a second, but it is relatively cellular. Right? Looking a little closer, you still see it is plasmacytoid. You can argue that there is some of these do have this classic salt and pepper chromatin. You can definitely have nucleoli in this specimen, especially in the pancreas. So some people will say like, oh, you don't see nucleoli in this entity, but you definitely can, especially in the pancreas. The cells themselves are, like I said, plasmacytoid, not horribly atypical looking, relatively round and smooth nuclear membranes. Luckily, these are usually very cellular on the cell block as well. So you actually usually have ample material for doing ancillary studies on. In this case, this is what the cell block looked like. And we did get a synaptophysin, which is blazingly positive. So we made the diagnosis of a neuroendocrine tumor. Usually neuroendocrine tumor, synaptophysin chromogranin positive is oftentimes all that your material you're going to have on a cell block. Sometimes people want you to grade it on the cell block. And I often get the question is, can you grade it on a cell block? My answer to that is you can, but you probably shouldn't. So the research I've done and the papers I read is that you tend to get undercalling, especially grade 2. So your grade 2 neuroendocrine tumors tend to get called grade 1. Grade 1s tend to get called grade 1. Grade 2 tend to get grade 1. Grade 3s are often appropriately called, but it's not as good as you'd like. So it is well known that you can technically do a Ki-67 or mitotic count, but that cell blocks routinely seem to undercall these. So sometimes it's better to not grade it at all. If your clinical team really wants you to, you can do it, but mention that there's a caveat that this may not be representative, and that's counting on a cell block tends to underestimate grade. So that's my one thing about grading it on a cell block.
All right. So moving on to resection of neuroendocrine tumors. So these are a few examples here, and you can see a very well circumscribed lesion within the pancreatic parenchyma. These often have this fleshy appearance on cut section, so that is pretty characteristic of neuroendocrine tumors. They can often be very yellow or whitish looking too, but very homogeneous cut surface if they've had a prior biopsy procedure, or again cystic degeneration in the center of the tumor, which has outgrown its supply. So you can see central hemorrhage or necrosis sometimes. And on histology, these are usually very well circumscribed. You may or may not have a pseudo capsule. Sometimes they can have a very infiltrative border. So that is, one of the prognostic features that has been recently described. So ones which are infiltrative into the adjacent parenchyma tend to do worse. But usually they are very well circumscribed. And again, architecturally, you can have a nested morphology. They can form sheaths of interstitial growth pattern. You can have trabeculae. Sometimes neuroendocrine tumors can be very cystic, especially the ones which have been biopsied or FNA'd before. You can see a range of morphologies. And here's a characteristic example of a nested morphology of neuroendocrine tumors. You can appreciate that these are very, very monomorphic. You can see abrupt pleomorphism, which is a characteristic feature of neuroendocrine tumors of any site, actually. So you can see abrupt pleomorphism, also called neuroendocrine atypia, but usually the cells are very monotonous. You can see very granular chromatin. Nucleoli can be conspicuous, but not that prominent. And then depending on the grading, you may or may not see mitosis. Usually mitotic figures don't jump out at you that easily. So pancreatic neuroendocrine tumors can arise at any age. The more common age group is 40 to 60 years, and no male or female preference can be seen in both sexes. And they may be functional, meaning they can secrete certain hormones such as insulin, glucagon, or gastrin, and can have clinical manifestations associated with that particular hormone secretion. Location wise, they can be located in any part of the pancreas, but more common in the tail, and they're often described in conjunction with some syndromes such as MEN1 and von Hippel-Lindau syndrome. On a molecular level, the well-differentiated neuroendocrine tumors often harbor mutations in the MEN1 gene or ATRX or DAX genes. So we went over pathology pretty much. Cytologic features could include oncocytic, rhabdoid, or they can be, some tumors can show a lot of neuroendocrine atypia, so that should not mislead you to diagnose a carcinoma. Usually in the well-differentiated neoplasms, if there's necrosis, it is either punctate or infarct type necrosis, but necrosis is not a criteria that we use in distinguishing carcinoma from neuroendocrine tumor anymore. And immunohistochemistry wise, they are positive for neuroendocrine markers such as synaptophysin, chromogranin, CD56. INSM1 is a newly described marker, which is quite specific. If these are associated with hormone secretions, you can have expression of that hormone demonstrated on histology by immunohistochemistry as well. So I would quickly point to the new WHO classification of neuroendocrine tumors, which has created this new G3 category within the well-differentiated neuroendocrine tumors. So before the 2019 WHO classification, it was any neuroendocrine tumor with Ki67 of more than 20% was classified as carcinoma. However, it was shown that certain tumors which have a well-differentiated morphology but have a higher proliferation index tend to do better than neuroendocrine carcinomas. And on a molecular level, these show mutations which are similar to well-differentiated neuroendocrine tumors such as ATRX or DAX genes. So these have been characterized now as grade 3 well-differentiated neuroendocrine tumors. And one would not typically want to use platinum-based chemotherapy in these cases because these wouldn't respond and would respond much better to somatostatin analogs. So quickly about grading. So you want to, on your MIB1 or Ki67 stain slide, you want to pick out the hotspot areas. So in this example, I've marked some hotspot areas. And what one would do is typically take a picture of the hotspot, print it out, and then count the positive cells, and then count the background negative cells, and get a percentage of positive cells, because eyeballing in our experience is not a good way to give a accurate estimation for grading. So I think I'll skip the details, but I can show some examples of poorly differentiated neuroendocrine carcinomas. We have the large cell type on the left, which has cells which are relatively large and have some degree of cytoplasm here, which we can see. There are abundant apoptotic figures, and the cells have large nuclei and prominent nucleoli. So these are features of large cell neuroendocrine carcinoma, and you can see the concurrent Ki67 stain slide shows a high proliferation index. In this case, it was above 50. And on the side, we have an example of a small cell carcinoma, and you can see there is a very high NC ratio for cells in this case, and barely any cytoplasm. And then there are some features of small cell carcinoma which you can appreciate, like nuclear molding. In this case, the cells are very fragile, so oftentimes you'll see a lot of smudge artifact associated with them. And then you have prominent mitosis and apoptotic figures, and the concomitant Ki67 index here was about 90%. So these are the two examples. Obviously, on small biopsy, sometimes it is very difficult to distinguish grade 3 NETs from neuroendocrine carcinomas. So especially when you have a small sample, when the morphology is ambiguous, when you don't have clear-cut features of a well-differentiated neuroendocrine tumor or carcinoma, when you have more atypia than you would like to see, and if the Ki67 falls in the range of 20 to 50%, it could be a real problem. And in those cases, one could use either immunostains or send tissue for sequencing. And if you have either loss of ATRX or DAX by IHC, or loss of RB or P53 by IHC. So loss of P53 or RB would point to a poorly differentiated neuroendocrine carcinoma, whereas loss of ATRX or DAX would show well-differentiated neoplasm. And then these can also be confirmed by sequencing. So I think that was, what do you want to do?
I mean, I guess we should just try to get through the last couple cases very quickly. I think these ones should be relatively quick, but we have about 20 slides to go, though.
Okay.
That way, because at least all the questions and stuff like that will be answered for the.
Okay, I don't see any open questions, so
Yeah.
we'll keep running through cases. So this was a 28, sorry, Matt, this was something you were going to talk about.
There's a 28-year-old woman presenting to the ER with abdominal pain. Basically, they have a 3-centimeter heterogeneous tail pancreas mass with some areas of cystification concerning for a neuroendocrine tumor. However, when they did the cytology, you can see that you have these very large, very cellular, very large clusters of sort of hyperchromatic cells. It's not that sort of monotonous population of plasmacytoid cells. If you look a little bit closer to them, you can see that they are very cleared out on the right. They have clefting, and they have, some of them have longitudinal grooves. You can sort of see that there are pseudopapillary areas. You can sort of appreciate the pseudopapillary areas on the cytology in the previous slide, and here you can kind of see it on the cell block as well. You could do IHC here to confirm the diagnosis, which we did, but that led to the patient getting a resection, which Marla can show right now.
Yeah, so on resection as well, you see this papillary morphology. Now it's called pseudopapillary because these are not true papillae. So these are very vascular tumors. And what happens is the cells which are away from the vessels tend to degenerate. And then the ones which are close to the vessels sort of hang on. So it gives rise to a papillary appearance, but these are not true papillae. And you can often see these hyaline or eosinophilic globules within the cells. So these are composed actually of alpha-1 antitrypsin. So one can do a stain to confirm that, but it's not necessary in our experience. So this is just a feature that we use sometimes in the diagnosis of these tumors. And oftentimes, similar to other tumors which may undergo cystic degeneration, and you have a lot of macrophages associated, you can see macrophages and solid pseudopapillary as well. Other than that, the cells per se are pretty monomorphic. You can see nuclear grooves and sometimes prominent nucleoli, but a close mimic would be neuroendocrine tumors. And so one needs to be careful with use of neuroendocrine markers, especially with this pseudopapillary morphology. Always important to do a beta-catenin immunostain, which would show aberrant nuclear expression. Sometimes neuroendocrine markers, especially synaptophysin, can be positive in these cases, usually very focal and weak, but it can be seen. So before you make a diagnosis of a papillary looking neuroendocrine tumor, always do a beta-catenin. These are also positive for CD10 and vimentin. So those are other stains which can be used. So again, these are seen in young women. They can be asymptomatic or present with abdominal pain, usually present in the tail of pancreas, solid or cystic masses. On a molecular level, these often show mutations in the beta-catenin genes. They are very, usually they have a very good prognosis, but rarely you have examples of metastatic solid pseudopapillary tumors, which can manifest very late after initial presentation. Immunohistochemistry, as I mentioned, beta-catenin, CD10, vimentin, P120 is another stain, which people who are more familiar with its use in breast might consider using, and then E-cadherin as well. They're also positive for progesterone receptor, TFE3 and LEF1. And atypia and high mitoses have often been shown to be associated with more malignant potential. So,
Sounds good. All right, case 8, 79-year-old woman being followed for primary biliary cirrhosis. She got an MRCP as part of her general workup, and it showed a multilobulated T2 hyperintense multicystic lesion in the neck and body of the pancreas. We did get a cytology on this. 9 times out of 10, your cytology is going to be negative on these cases. You're going to get blood, you're going to get histiocytes. This is one of the few cases I had where I actually have the cells of question. So the cells are very bland, high NC ratio, low NC ratio, epithelioid looking cells. The nuclei, you could argue it's plasmacytoid. The nuclei has that very, very sort of fine chromatin. It's not chunky at all. Like, it's not that salt and peppery. It's very paucicellular. We did have a corneal biopsy on the right. Actually, I believe this is actually a PAS stain as well. But you see sort of that sort of characteristic, is very characteristic, but mostly you're just going to get blood and histiocytes. I very rarely see these actually being diagnostic. You have more images of the fine needle biopsy over here. So basically you have this sort of hyalinized stroma, and you do see these the cystic areas lined by these very bland cuboidal cells. Then these also have a very distinctive gross appearance as well. Is your first sort of sponge? Oh, sorry, I think this is your case. This part.
Yeah, so on gross examination, they show this very fine microcystic appearance. They almost look like sponges, one might say, and often have a central scar. And sections from this show back-to-back cysts with very thin fibrous walls between them, and often some areas of scarring. And then the lining, as described, is very bland cuboidal epithelial cells. One thing to note is very monomorphous, very dark hyperchromatic nuclei, often described as ink dot nuclei. So an important feature to consider when looking at biopsies of these lesions. And again, one can show PS positive granules. These often shows positive staining with CA9 because they have the same hypoxia pathway in the pathogenesis. So they're positive for CA9. And often we don't see resections of these cases because these patients just get followed up. They have a very benign course, but sometimes when they have atypical appearance on imaging, then patients may end up getting resections. So usually they have this small multicystic appearance, but oligocystic variants of serous cystadenomas have also been described. And one must be aware of that while dealing with cystic neoplasms as well. Those specimens tend to be even more hypocellular and may only show rare cells, which would be diagnostic of this entity. Immunohistochemically, they show expression of carbonic anhydrase 9, inhibin, calponin, or GLUT1. And on a molecular level, they may show mutations in the VHL gene. Moving on to the next case, this was a 77-year-old woman with an incidental tail of pancreas lesion. It was a 2 centimeter T2 hyperintense, patient had 2 lesions actually, T2 hyperintense well-circumscribed lesions in the tail of pancreas. And the imaging features of these lesions were very similar to the adjacent spleen. So that was a clue. And biopsy, you can see this proliferation of very, very busy looking tissue with lymphoid type infiltrate, so very inflammatory looking tissue, and lots of blood and fibrin in the background. Sometimes if you get lucky, you may be able to appreciate some vascular channels, like in the bottom right image, you can appreciate some vascular channels lined by very bland cells. So that could be a clue. When you do your stains for lymphoid markers, you'll see that CD3 would show scattered positivity in these cells, inflammatory cells, but CD8 would nicely line those vascular channels. So these are the littoral cells which line the vascular channels of spleen. So the diagnosis in this case was sampling of an accessory spleen or splenio. And on resection specimen, you can see, this is another case, just an example of a nice gross example of spleniole. Sometimes residents can mistake these for lymph nodes and put them in distal pancreatectomy specimens as lymph nodes, but the gross appearance pretty characteristic, very hemorrhagic cut surface, and have a very distinct capsule. So next.
I'm going to very quickly go through this case. We have time for a couple questions. Long story short, 65-year-old woman, history of breast cancer that we were not given, very distant, not really a good historian. They had this really worrisome finding on their MRI. Actually, it's very characteristic of a pancreatic ductal adenocarcinoma. It's a 3 centimeter mass in the head of pancreas causing obstruction and bile duct dilatation. We got a core needle biopsy on it. And it shows this obviously invasive adenocarcinoma, very eosinophilic large cells, kind of bringing to mind perhaps acinar cell carcinoma. But digging into the chart, we found the history of breast cancer, and I did sort of a workup for that first and foremost. And this was positive for GATA3 as well as mammoglobin and ER. All that together is very definitive. So this person has a sort of very distal, very distinct sort of separate metastatic spread of their breast cancer like 20, 30 years down the line, which can very rarely happen. We'll quickly just go over another very common type. This is another sort of appearance of metastatic at low power. You can sort of see it's a well-circumscribed nodule. And if you look closer at it, it's packeted clear cells with cytologic atypia. This is very characteristic for clear cell renal cell carcinoma. Of course, you do have to correlate that with patient clinical characteristics and imaging. Interesting to note, they sort of come up a few times. VHL, you see, of course, renal cell carcinoma. You also see serous neoplasm, which can have clear out cytoplasm, and you can also see clear cell type neuroendocrine tumors. So you always want to keep these things in the back of your mind if a patient has VHL or any indication of familial cancer syndrome. In this case, though, it was PAX8 positive, it was CA9 positive, it was and the person had a history of clear cell renal cell carcinoma, so it was diagnostic. Mets of the pancreas can be seen. The most common, oddly enough, I think, is kidney. You definitely see melanoma, breast, other GI tract, and lung. Oh, sorry, this is Monica's part. Sorry, I took it. But I've also seen multiple, it's covered with the spleniole. I've seen multiple lymphomas actually present in the pancreas as well. So something just to keep in the back of your mind. Sorry about that, Monica.
No, that's fine. Yeah, so this was just a diagnostic algorithm for diagnosis of solid lesions of pancreas. And I think we've gone over all of these in detail, so we can skip that. And I think that was all we had. Yeah. So we have a few minutes for questions and happy to stick around as well. So thank you all for your time and attention.
Yeah, of course, we're also available by email if you have questions later on that you want to let us know about.
Absolutely, yeah. While we're waiting for questions, this is a very nice aerial view of Boston, and this is this Fenway Park Stadium, which is the home of Boston Red Sox. Don't ask me much about sports, but yeah, interesting bit of trivia is the hospital that we work at, Beth Israel Deaconess, is the official hospital of the Boston Red Sox as well. So yeah.
So thank you guys so much, Monica and Matthew. This has been really great. Unfortunately for our audience, we are at time, so we won't have time for questions. There aren't any open questions. However, if any of you do have questions about the presentation, please feel free to email us and we can make sure that Matthew and Monica answer your questions. Again, thank you so much for participation today, and we will see you all on Thursday.
Thank you very much for having us.
Thank you so much. Thank you. Really enjoyed this.
Thanks. Bye, Gloria. Thanks.